Good morning, and thanks very much for the opportunity to come along and speak this morning. I'm going to talk for the next 20 minutes or so really on some of the changes the ambulance service has gone through over the last couple of years and some that are coming, some of the engagement we've had with nursing and residential homes over the last 2 years, and then some opportunities which I think there are for the future, especially coming into winter pressures. So I just want to give you a wee bit of a background on the ambulance service so far. We are the sole ambulance emergency provider in Northern Ireland. You'll see other ambulances out there, Red Cross, St John's, a lot of private providers, but in terms of 999 emergency work, we're the only one. We have 59 deployment points around the north. Now that ranges anybody from Ballymena direction. We have a nice sexy new ambulance station up there, all the way to some porta cabins that probably should have been condemned a number of years ago. So a full range. We have two control centres, the emergency control centre, which is based up in Knockbracken, so when you ring 999, that's where you go through, and then the non-emergency control room, which is based up in Altnagelvin. So for any of your clients that will be going in and out of hospital on a regular basis, generally people who have dialysis, you would go through the Altnagelvin centre. We have one regional education and training centre, which is up at Knockbracken as well, but we're really pleased to say that from January going forward, paramedic education in Northern Ireland is going to go through universities, so it's caught up a little bit with England and the UK, and similar to nursing now, all paramedics in the future will go through the university route. And we have 313 ambulance vehicles. Now that sounds like a lot, but that's all the emergency ambulances, all the non-emergency ambulances and all the reserve. So we really don't have a huge amount of vehicles. In Belfast today there's 7 emergency ambulances covering the city. I don't know if that sounds like a shock to some, but so we're in a unique position now where there's calls waiting on ambulances instead of ambulances waiting on calls. And then we employ in excess of 1,200 staff. Now, the reason that's important is when we're trying to influence change, we're up against the trusts. Sounds like a bit of a competition, but we all get on well. But we are up against the trust. So if we compare the Belfast Trust that has about 24,000 staff and a budget of 1.1 billion, and we have 1,200 staff and a budget of 70 million, it's a bit David and Goliath. So we have to push really hard for change. In fact, the Belfast budget for catering is about 70 million. So what the Belfast Trust spend on sandwiches and scones is what we have to keep us going for the year. In terms of what we do, in 16-17 it was just over 210,000 calls, which is just under 600 a day. Now, on a good day with the sun shining and a fair wind behind us, we have 60 A&E ambulances out there, and they're supported by 20 rapid response vehicles, so the little cars you see driving about. But that's covering the entire of the north, so 5,500 square miles and 1.8 million of a population, so it's really not sufficient to cover all our demand, meter demand, and demand's gone up year on year by just under 5%. The non-emergency ambulance tier, they have 65 ambulances, so that's the white ambulances you see driving around, and they just do just shy of 550 calls per day. But most of their work, so about 38,000 of their calls come from GPs. And you probably see both coming in and out of both nursing and residential homes, the yellow ambulances and the white ones. So this was our traditional model up until a couple of years ago. Every 999 call generated resulted in an ambulance response, which resulted in the patient being taken to the ED. And it's really not always appropriate. So some examples of inappropriate calls, young lad who had chest pain, but it was because he had waxed his chest because he was going to Ibiza the next day. A lady who had bit her tongue but came through as vomiting blood. Somebody else who had squashed a spot in his head but came through as traumatic brain injury. You could argue if there was a brain in there in the first place. And a personal favourite from last week was a lady who had a little bit of pain following a bikini wax. So there's a few grimaces there. Is that more painful than what we give credit for? But these, up until a couple of years ago, these type of calls, we were turning up and we had to take them to hospital because we didn't have an alternative. So we've changed, and the reason we've changed is demand, I've said, is gone up. As you know, we have an ageing population and chronic conditions, so COPD, dementia, deliriums, this is all relatively new terminology to the ambulance service. Years ago it was all about the trauma, whereas now it's all these long-term chronic conditions. A number of strategic drivers has really influenced this. So the QO report in England, QO suggested that 50% of 999 calls should be managed in the community. They don't need to go to hospital. And then locally, transforming your care. I know there's mixed opinions on it, but for the ambulance service, it was a real kick up the bum we needed to change what we're doing, so we are a big fan of it. And Bangoa, and they suggested appropriate pathways, make better use of your ambulance service, keep people in the community when safe and appropriate to do so. And And then cultural expectations. We've really seen the culture change in Northern Ireland in that people want rapid access to healthcare, convenient healthcare. We know there's troubles with primary care. We know it's not always easy to get to see a GP, and then they call an ambulance when they understand that they're going to be seen quicker in the ED, and that's not always the case now. So if we feel that the patient's not appropriate for ED, we don't take them. If they need ED but they don't need to be seen urgently, we just drop them at the front door and send them to the waiting room. So we've really changed how we're delivering our service. And this is just to give you an idea of why people call 999. So we asked the question, we asked the general public, why do you think people dial the ambulance service? And car crashes come in, cardiac arrest come in, trauma come in, but actually they're numbers 12 and 18 on the list. So major trauma, we only get 1 per day across Northern Ireland, thankfully. And cardiac arrests, it's only 5 per day across Northern Ireland. But even those 5 cardiac arrests, some of those are in nursing and residential homes. And are they a true out-of-hospital cardiac arrest, or is that the natural end of somebody's life? Should we be doing resus on some of these patients? So actually most of our work now, number 1 is doctors' calls, just under 70,000, and falls, so almost 24,000 people a year now call because they've fallen. And we kind of know that. We know the population's getting elderly, we know there's risks of falls, and we know all the complications with that in terms of neck and femur fractures and the mortality of that afterwards. So really our job has changed from trauma and that true acute emergency service to more an extension of primary care and an urgent and unscheduled care service. I don't know if that surprises you or if that's what you had kind of thought now. But to meet this new demand then, we introduced a number of pathways. Now, I'll not take you through all of them, but just a bit of a highlight. So diabetes, and I know in the previous session we talked about the hypo session. With diabetes, now if we turn up to somebody who's having a hypo, we have a range of treatment options, and we're generally very good at treating them unseen, and they make a full recovery. And it used to be we'd leave them at scene, go away, and then we'd see them a few days later, and it was just a bit of a cycle. So now we refer them back to the diabetic specialist nurse, and then they have the option. So they'll make contact within 48 hours and then decide what's going to happen next. So can we give some advice over the phone? Do we need to take this patient back in the clinic? Do we need to do a medication review? And the idea is that we get the hypo first time and try and prevent it from happening again. The cardiac pathway is for people who have a heart attack, or I think your session as well said AMI, the acute myocardial infarction. Years ago, we just went to the nearest hospital. Hopefully nobody in this room has a heart attack today, but if we did, we wouldn't go to the Mater. We would drive straight to the Royal, and actually we bypass ED and go straight to the cardiac suite, and we're met by the cardiologist. So the cardiac pathway, I think, is a fantastic service for people in Northern Ireland, and we have 2 centres, one in Belfast and one in Knocknagelvin, which means now, depending on where you are, we will drive past a number of hospitals to get you to the right care first place, or first right care, right time. The community nursing referrals, when we initially engaged with the nursing and residential homes, this was met with a little bit of controversy, and one of the benefits of this pathway is for people with blocked catheters. So again, if we had been called out previously somebody with a blocked catheter, we had to take them into the ED, and now we can ring district or community nursing and they can come out and resolve or resite the catheter. Now, some homes said, well, we've got the capability to do that in-house, and we're slightly offended that we put this pathway in place. But other homes said actually the turnover of staff means it's quite difficult to keep our staff skilled in reciting catheters, and actually that's a beneficial service for us. So we didn't go out to offend, it's just trying to keep people at home if it's safe and appropriate to do so. And we welcome feedback on any of these pathways, so feel free. Robert has our contact details and he can circulate them afterwards, but feel free to contact us and let us know if you think it worked, if it didn't work, why not, and what could we do better. The falls pathway, in terms of numbers, is probably our greatest success. So that ranges anywhere between 200 and 300 referrals per month. And that's for anybody over 65, whether they're in their domestic address or a residential home or a nursing home. If they've fallen and they're uninjured and they're safe to be left at home, then we refer them back to a falls team. Now, Northern Ireland is the only area in the UK that can boast of having a 24/7 regional pathway for this. The falls coordinators in each of the trusts have done a fantastic job. And what that means, if we make a falls referral, they will follow this patient up within 48 hours, and then they decide what's needed. So sometimes it's telephone advice, sometimes it's a referral for stepping on programs or stepping up programs, and sometimes it's brought into clinic for a multidisciplinary review where they get physio, OT, nurse, pharmacy support, or sometimes the OT and the physio will do a home visit. So it really depends on the nature of the fall. And the aim is to prevent the secondary fall, to prevent the neck of femur, and everything that's nasty that's associated with that. And then the last one I'll touch on is just the frail elderly pathways. There's a range of them. We have acute care at home services, and Belfast, I think, is one of the best areas to get old, if that's a good way of saying it, because they have an acute care at home service who will come to your house. But equally, we have BCH Direct, so I don't know if any of your clients or residents have been transferred to BCH Direct, but that's a specialist unit in the city hospital for frail and elderly people. And we would transport a lot of people there from the nursing and residential homes within the Belfast locality, and they're seen by consultant geriatricians, so no wait in the ED and a much better patient experience. So that's just an idea of some of the pathways that we've introduced, and what that means now is that 1 in 4 of our patients we no longer transport to hospital. We have a 25% non-convey rate, which frees the ambulances up to go to some of the more life-threatening calls. Another big change that we introduced last October was the notion of a clinical support desk. So again, prior to last October, if you dialed 999, you would have spoken to an EMD who's not clinical, and your call would have been prioritised, put in a queue, and then we would get to you when we could. Whereas now we have 10 specially trained paramedics who work in our control room from 7:30 in the morning to midnight. And when you ring 999, if it's appropriate, you will be transferred to speak to them. They use a system called Manchester Triage, which is used around the world, predominantly in EDs, but starting to filter out into ambulance services. And it's really looking for red flag symptoms. Is this a patient whose life's in immediate danger, in which case we need to come out to you now? Or is this a patient we can do something a little bit differently with? So can we book the transport for maybe 2 or 3 hours down the line? Or can we get the acute care at home team to come out, or a district nurse to come out? So it just gives us options. And the sole aim of it then is to provide a hear and treat service. So you actually get help over the phone without the paramedic actually coming through your front door. So this is the new look ambulance service now. No longer do we always take you into hospital. We have a range of alternative destinations, a range of treat and leave services, including one that's on there, which is palliative care. Now, palliative care is not big in terms of numbers. It's probably only 5 to 6 per month, but it's, I think, really important in terms of patient dignity and patient experience. So these are patients who are approaching the natural end of their life. They're in the last hours of life. Something happens where there's an acute exacerbation and the ambulance service is called. Previously we would have turned up, we had 2 blokes or 2 females, but people like me and Chris turning up and doing aggressive resuscitation, bringing the patient into hospital, and then they either had an extended period of stay in hospital or they died, but they never recovered. Whereas now we can ring Marie Curie or district nursing services. They can come out and commence syringe drivers or give hyoscine for secretions. They have a range of options to them now. But what it means is that patients get to stay in their own home and have a dignified death. And then some nursing home engagement, which has happened over the last couple of years. I think our relationship and the engagement with nursing and care homes in general has really improved over the last couple of years. We've had regional meetings with all the trusts, but we've also worked very closely with the RQIA and the PHA. And on the back of all those meetings, we've designed an infographic of when to call 999. Have you seen these in your homes? Some yeses, some no's. If you haven't, again, feel free to contact me and we can send them out to you. And we did some engagement with our own staff around escorts. So I'd imagine you've all had the grumpy paramedic at 4 o'clock in the morning asking who the escort is going to the hospital. So we have let our staff know now that it's not always possible, that staffing levels within the home doesn't always permit sending an escort. The reason they ask is that when we take somebody to hospital, we leave them in the ED and they go. And for patients with dementia or delirium, in the next hour, they may see a nurse, a domiciliary care worker, a phlebotomist, a porter, the X-ray technician, the radiographer, a junior doctor, a senior doctor. And the patient experience isn't really good if they're alone, so that's why they ask for an escort. What we would ask is if you are calling an ambulance, that you ring the family at the same time, and even if the family can't meet us at the home, even if they meet us at the ED, just so there's a familiar face there that when we drop the patient off at the ED. We've delivered some joint training with Jan Ritchie, who's one of the consultant geriatricians in the Belfast Trust and the acute care at home team. And that was delivered to nursing home staff in Belfast. We got really positive feedback, and we're delivering another session now on the 11th of September, so next week. And we focused on exactly what you were saying earlier, the deteriorating patient, recognition of them, and use of the National Early Warning Score. I'm a big fan of the National Early Warning Score. We've seen it used in hospitals. On the back of it being used in hospitals, the ambulance service brought it in. And I feel if nursing and care homes brought it in, then we'd all be speaking the same language. So I think it would make things a little bit easier. And then RQIA standard 22. So again, a couple of years ago, we would describe inappropriate calls to nursing and residential homes for people who had fallen but were uninjured. And the reason we were called was because there was a no lift policy in place, and it was just literally to lift somebody off the floor. Now the first slide wasn't a plea for help, but you can see why we can't go to those calls, because we just don't have the resources. So thanks to the RQIA, we put in standard 22, which basically says only call an ambulance if there's a genuine medical emergency, and then the poster went out to support that. And then future opportunities. On a practical level, if you're ringing 999, let us know the door code to get in, especially in the middle of the night. It's not always easy to get into the homes, and sometimes we wait 5 or 10 minutes at the front door. If you just tell during the 999 call, this is the front door code, we can let ourselves in, and then you'll hear us when we're inside, we shout. GP engagement, we understand your struggles and the trouble with primary care. We understand the pressure in primary care, but following engagement with yourselves, we understand that it's difficult. But we continue to work with primary care and advocate that they get into the care homes and do the advanced care planning and end of life care planning, because I feel that will prevent unnecessary resuscitations if the care plans are in place. The other opportunity is around wheelchair taxis. So some homes have already got contracts with taxi services that offer wheelchair services, and these are for patients who have routine hospital appointments. If you have access to a wheelchair taxi, that may expedite the patient's journey rather than waiting 2 or 3 hours on an ambulance to turn up. So it's something that I would encourage that you explore, especially coming into winter pressures. But the big one for me going forward is the North West Ambulance Service, in collaboration with a number of nursing homes, adopted the Manchester Street triage tool for nursing homes, and then noticed that calls to the ambulance service went down and that appropriate care pathways in the area were used slightly better. So I don't need a show of hands now or volunteers now, but if you were willing, or your home was willing to work with the ambulance service, we'd be keen to work with 2 or 3 homes to try this tool out and see, can we reduce calls to the ambulance service, can we reduce ED admissions, and can we make better use of pathways that's in the area. So that was kind of a whistle-stop tour of the changes and some engagement with nursing homes, and some opportunities for the future. Thank you.